Happy New Year to all. Good evening to everyone. On behalf of Association for Veterinary Dermatology India and INTAS Animal Health, I welcome all of you for the wonderful dermatology webinar, which is of very much useful for the practitioner. See, we have a lot of cases which are having a similar symptoms, like we have a lot of pyoderma, hair loss, crust, and scratching, sometimes without scratching, and it will have a lot of ugly appearance. So that is the presentation in many cases. See, one of the important disease is autoimmune disease in case of skin issue. So the autoimmune disease has to be we have to understand that, and then we have to tell the prognosis to the owner. See, the prognosis and treatment of what you are going to give has to be described to the owner. Then only we will be successful in the management of the disease. So it is very important to identify. You and me will be having the disease, but we may not know this is the disease. This is an autoimmune disease. This is a pemphigus. See, the pemphigus is one of the important autoimmune disease which is very commonly seen in our practice. But most of us will be having the disease without knowing it is a pemphigus. So it is very easy to identify that in practice and easy to follow. But the whole thing has to be informed to the owner, and we have to prepare the owner to go for treating it, and we have to tell what will happen and what are all the means by which it can occur like that. So to enlighten that particular issue, today we have our chief guest, that is speaker, Dr. Sunita Choudhary from Rajasthan Veterinary College, that is Bikaner. She is a faculty in clinical veterinary medicine. So she has done a lot of work in pemphigus foliaceus, and so we thought we will share, we will get more information from her. I welcome her to go for the webinar. Thank you. Thank you.
Good evening, everybody. Thank you, Association of Veterinary Dermatology and INTAS, for giving me this opportunity to share this topic with all of you. So today I'm going to share with you the diagnosis and management of pemphigus, an autoimmune disease in dogs. So starting with an introduction, what is the meaning of this pemphigus? So this word has been derived from the Greek word which means blisters. So pemphigus is a complex which is an autoimmune disease which is shown as a vesiculobulbous to pustular skin disease, and it is characterized by acantholysis or loss of adhesion between keratinocytes. So this is the way on the epidermis the vesicles and the bullae will be appeared in this condition. So again, understanding what is exactly happening in the skin. So this is the normal skin anatomy, where this is epidermis layer and then dermis layer. So what we have to focus is, in this pemphigus disease, mostly the condition happens on the epidermis, and in the epidermis there are different keratinocytes, as you can see. The cells of keratinocytes which are adhered to each other. So in this condition, this is a normal where all these are attached to each other, but in this condition there will be lysis of these keratinocytes and the adhesion will be loosened. That is the one which causes the acantholysis. So pemphigus produces lesions that are restricted to the epidermis, as I already told you. The more specifically, these lesions are suprabasical, each variant being characterized by location within the epidermal layer and by the location of lesion on the body. So inside the epidermis also, this pemphigus complex condition will be seen in different layers of the skin, and also on the body there will be different location wise the distribution of lesions will be present, which will help us to differentiate among the pemphigus conditions. So there are 5 forms of pemphigus have been recognized: pemphigus foliaceus, pemphigus erythematosus, Panepidermal pustula pemphigus, Pemphigus vulgaris, paraneoplastic pemphigus. So among these, the very frequently or very commonly autoimmune pemphigus which is observed is pemphigus foliaceus. Coming to the etiopathogenesis, so usually there will be development of autoantibodies from an abnormal immune regulation or abnormal antigen stimulation, or there can be a strong genetical predisposition, like in example in cases of Akita breed and in Chow Chow breed. They are genetically predisposed to this autoimmune condition. There are also been seen that infectious agents have been involved, especially the viruses been involved, which has been transferred through flies. They also causes this condition. In some cases, drug-induced or chronic skin diseases, when it is been present, this causes uh, long-term usage of drugs like penicillamine or trimethoprim potentiated sulfonamides, cephalexin. They are also being the cause for the predisposition of this pemphigus condition. The possibility of ultraviolet light irradiation also causes acantholysis, which is seen in pemphigus. So overall, in a broadly, what is happening in pathogenesis is the epidermal cell membrane which is present. On that, there will be binding of autoantibody to an antigen, and that causes release of some enzymes, which leads to disruption of intercellular attachment of keratinocytes, and that disruption of attachment causes acantholysis and in turn leads to pemphigus lesions. Now, what are these antigens against which the autoantibodies are produced onto the skin? So for that we should understand the main important thing is desmosomes. These desmosomes are the one which are intercellular adhesion structures in the epidermis and in the mucus and also in the myocardium. So these desmosomes are the one which causes the which are the main which maintain the cell to cell structural integrity. They adhere the cell with each other. So these desmosomes are the one which is present in epidermis and also in the mucosa, which is very important in this disease condition to understand. So again would like to show you the structure of the epidermis, in which you can see these are the desmosomes which is adhering the keratinocytes to each other. So these are the interconnecting proteins which are being which can be seen. So what is happening? These acts as an antigen, and antibodies within the body will be produced against these desmosomes, and hence there will be lysis of this adhesion, and keratinocytes will be the attachment will be loosened and causes acantholysis. Keratinocytes are firmly adhered by desmosomes. So any disease which causes the disruption or weakened desmosomes may lead to loss of cell-to-cell adhesion. This process is called as acantholysis. Now in the skin, the desmoglein 1 is expressed. So there are the proteins uh, which is termed as desmoglein 1 and desmoglein 3. So the 1 is expressed throughout the epidermis, and more intensely, but very commonly, it is on the superficial layer, where desmoglein 3 is expressed in the deeper layer, that is basal layer of the epidermis. So this is the diagrammatic presentation I would like to show you, that desmoglein is 1 is distributed on the whole epidermis and 3 is distributed on the basal layer. So when the antibodies are against desmoglein 1, the superficial cells of keratinocytes will be loosened, and this happens in cases of pemphigus foliaceus, and the blistering happens on the upper epidermal layer. And in case if it is against 3, the basal layer will be affected, and the keratinocytes will be loosened on the basal layer. So the blistering occurs on the basal cell. So this is the, and so this causes more of deeper erosion, and this happens in Pemphigus vulgaris. So this is the main difference pathogenically happening, which differentiate these both conditions. So the antibody, so what is basically happening in this disease is autoantibodies are produced, which are targeted against desmosomes, which is the adhesive protein in between the keratinocytes. There will be loss of cellular adhesion and leads to blister formation, and that is the clinical symptoms of pemphigus. So, so you can see here in the picture, the in Pemphigus foliaceus, the superficial layer has been affected, and the blister will appear in between these cells on the superficial layer of the epidermis. The type of pemphigus, the type and severity of clinical signs. So we have already shown that there are different forms of pemphigus. So how these forms have been categorized based upon the same which part of desmosome has been affected, or the antibody is produced against which desmosome. So the type and severity of the clinical disease that develops and depends upon the type of anti-desmosomal antibodies produced. So the superficial one, for example, when the antibody target proteins within the superficial expressed desmosome, that is desmosome 1, the pemphigus foliaceus develops, and it only affects the skin and it does not affect the mucosa. Trust, when the antibody target desmosomes in the deeper layer of the mucosa, that is desmoglein 3, deep erosive and vesicular muscular predominant variant of Pemphigus vulgaris arises. So in this case, the mucocutaneous form of Pemphigus vulgaris is associated with antibodies against both desmoglein 3 and desmoglein 1. So hence, in case of Pemphigus vulgaris, we will see the skin also affected and also mucosa. The mucosal layer also will be affected. Whereas in Pemphigus foliaceus, it is only the skin which will be affected. So again, the picture to clarify which type and which layer has been affected. In the Pemphigus foliaceus, superficial epidermis. The superficial layer of the epidermis is affected. This is the layer where the skin lesions will be appearing. And in Pemphigus vulgaris, the basal layer will be affected and the lesion will appear on this side. So this is important because when we are doing the diagnosis based upon the histopathology, so which part has been affected will help us to differentiate among pemphigus, which is the condition which is shown. So again, similarly, mucous membrane will be affected. As I told you, it is only in the Pemphigus vulgaris. So antibody which is produced is IgG basically, which is against desmoglein 3, and in epidermis, if it is involved on the skin, it is only in the Pemphigus foliaceus, only epidermis is been affected, whereas in Pemphigus vulgaris, both mucous membrane and epidermis against both desmoglein 1 and 3 antibodies will be produced, and the lesions will be seen in both the skin and the mucosa, and it causes deep blistering. The lesions appear in the form of deeper layer will be affected. That is it for Pemphigus vulgaris. Classification of pemphigus. So based upon this, it is broadly classified into superficial and deep form. Superficial pemphigus foliaceus, pemphigus erythematosus, and in the deeper it comes pemphigus vulgaris, pemphigus vegetans, and paraneoplastic pemphigus. Now coming to the pemphigus foliaceus. This is the most common form of pemphigus in the dogs, and it is basically characterized by scaling, crusting, which is a common clinical symptom. Hence the name is called as foliaceous, means leafy. There is no gender or age-wise predilection in this condition. It can be seen in any age group of the animal or dog or any gender. Breed-wise predisposition is being observed by some authors like Coley, Akita, Chow Chow, Newfoundland, and Doberman Spinter are generally predisposed. They are genetically more predisposed. And apart from that, English Springer, Spanish, Chinese Sharpeye, and Coley have been shown to be at increased risk. Now coming to the clinical signs of pemphigus foliaceus. So basically, uh, it is a condition of vesicle and bullae formation, but since they are very fragile, when the case is presented to us, the vesicle and bullae may not be persisting on the lesion. So they break and then there will be formation of epidermal colrates. So when the animal is presented, it will be more of pustular and erosive bordered by the epidermal colrates. These are the lesions which will be seen. And also it is important to see the distribution of the lesion. So pemphigus foliaceus mainly it is the clinical sign and appears on the facial region, on the pedal, and or it can be generalized form. Footpad lesions will be so much arithmetic swelling will be seen and cracking, and there will be villous hypertrophy like a hard pad. So this is the area of distribution of pemphigus foliaceus. So you can see it starts basically from the face. Nasal septum will be affected, ear pinna will be affected, foot pad will be affected, and in generalized form they will be distributed throughout the body, basically on the axilla also, groin region, abdomen, lower abdominal region also. So apart from these lesions on the body, there can be pain and pruritus, which is variable upon depends upon the severity also. And sometimes there can be anorexia, depression, and fever, as in very severely affected animals. The systemic involvement can be observed. Now, showing the symptoms, the most common site involved in the dogs in pemphigus foliaceus. Very, very typical signs you can see, as already discussed, there will be erosive lesions. So you can see the periorbital area, the lesions is present. On the muzzle, the lesions will be present, and very erosive lesions. So this is the typical clinical symptoms which you can observe. Again, very, very sloughing kind of lesions will be present around the eyes. You can see the nasal septum has been affected, muzzle is affected. This is the ear pinna, sloughing of erosive, typical erosive lesions. So this has to be easily you can differentiate once you see the clinical symptoms, and if in case we have to differentiate it, it will be basically from the dermaticosis or pyoderma, deep pyoderma. We have to differentiate. But basically, when the animal is presented, you will know that the treatment has been given previously with the antibiotics. It is not responding with that. So, and still these lesions, typical lesions have been present. So you have to think about the autoimmune pemphigus disease. So epidermal choroids have been present, very severely affected animal. So foot pad is also affected. Now pemphigus erythematosus is the benign form of pemphigus foliaceus. So these are little localized form will be seen and restricted to the face and ears. The coolie and German shepherd are more predisposed to this disease. This is not very serious compared to the pemphigus foliaceus. It is a localized form of the pemphigus foliaceus, which is pemphigus erythematosus. So there will be depigmentation of the nose, and then there can be a photodermatitis, which is possible in this case. Probably a photosensitivity form of pemphigus foliaceus, primarily restricted to the face. So this is only restricted to the face, not generalized for things. So you can see the nasal septum is affected and periorbital lesions have been seen. Next is Pemphigus vulgaris. So this we have seen is the form of a deeper form of pemphigus. This is the rarest form of pemphigus, accounting for less than 0.1% in cases of referral cases in dermatological specialty practice. But it is a more severe form of pemphigus since it is a deeper layer have been involved. So prognosis also will be little difficult to treat also. Lesions are erosive and ulcers of the mucocutaneous junction and oral cavity. So the important thing which you have to be differentiated from pemphigus foliaceus is that mucocutaneous junctions are being involved, and very important is the oral cavity is being involved. The vesicles are again rarely seen because they are very fragile. And according to the Muller, he has reported that 90% of the dogs and cats with Pemphigus vulgaris have oral lesions. So very important that when the oral cavity, it is any erosive and ulcerative lesions you are finding, you have to suspect for the Pemphigus vulgaris. Though the location of the lesion again in this Pemphigus vulgaris is the oral cavity, very important one, axillary region, groin, flank, mucocutaneous junction, that is lips, nostrils, eyelids, nail beds, genital and anus, and foot pads. So I would like to show you the pictures. So this is the oral cavity. Totally the lips, mucocutaneous junctions have been erosive, very erosive lesions you can see. The skin has been involved. Lips have been involved, gingiva has been inflamed and erosive. The lower lip, the upper lips have been eroded, erosions have been present. Ulcers you can see inside the mouth cavity, the ulcer is also been present. So when this type of lesions are being presented to you, you have to think about the autoimmune condition. So once when you see even one case, if you can see clinically, then it is very easy to differentiate from the other conditions also, because the lesions are very typical, so erosive, even the tongue will be involved in this condition. So gingiva, even the palate will be involved in this condition, pemphigus vulgaris. So all the erosive and ulcerative lesions which is being present will be very typical of pemphigus vulgaris. The next is pan-epidermal pustula pemphigus, also called as Pemphigus vegetans. It may be a variant of Pemphigus foliaceus, although the pustules may be deeper. So this is also related to the Pemphigus foliaceus, but this is a deeper site of the deeper layer of the epidermis will be involved. The lesions are clinically same as facial Pemphigus foliaceus. So there will be presence of pustule within the epidermis and follicle epidermis. So this is the pictures of Pemphigus vegetans, the pustular lesions in the deeper layer. Next is the paraneoplastic pemphigus. It is a rare form of pemphigus and has been seen in association with tumors such as thymic lymphosarcoma, mammary carcinoma, Sartorius cell tumor. So the important thing for the diagnosis of this pemphigus is the history, physical examination. Then after that if you have the facility, you can go for cytology and histopathology. And in cases of research purpose, if you are going, immunofluorescence is a very good technique to diagnose. Coming to the history, very important. As such, there will not be a very specific history will be present, but whenever the dog is presented, definitely the history will be that as I have shown you the cases of the pictures of those cases, the history was that the animal has been treated with antibiotics or antifungal for a very long time, 2 to 3 months. Still, there is no response to the therapy. There is no improvement in the condition by the antibiotics which has been given. So that is one of the important, if it has been referred case, it will be very important for you to diagnose if it is not responding with the antibiotics or antifungal agents, or if you have ruled out demodicosis also, then easily with the clinical symptoms you can make out it is an autoimmune condition. Then physical examination. So you have to see the nature of the skin lesions. So as I said, whether it is a superficial layer has been involved, pustules have been present, crusty lesions are present, or it is deep layer, erosive and ulcerative lesions are present. So it is very typically erosive and ulcerative lesions, which I have shown you in the picture, will help you to diagnose it is an autoimmune disease. Then distribution of the skin lesion is very, very helpful for you to differentiate from the other conditions. The facial area which has been involved, the ear pinna around the eyes and the nasal septum and the muscles, very, very typical for the pemphigus foliaceus. And if the mucocutaneous junctions are involved, oral cavities are involved, pemphigus vulgaris. So the type of skin lesions which have been seen and the distribution of the skin lesions, which will definitely help you to diagnose the autoimmune disease only by the physical examination and the history. Then you can go for any other abnormality of the systemic involvement of the condition is there or not. That depends upon the severity of the disease. Now, if you have some further diagnostic tools in your hospital or facilities, you can go for confirmation of autoimmune disease by cytology and histopathology, because autoimmune disease can be totally confirmed by the presence of this acantholytic keratinocytes. So if you have the facility, you can go for cytological examination and then you can easily confirm by presence of acantholytic keratinocytes. This cytology can help to confirm the presence of secondary bacterial infections also and it will help you to differentiate from the bacterial infections also. So this is the picture diagram showing the acantholytic cells present along with the lot of neutrophils. So this is how it will maybe appear in the the acantholytic cells will be quite larger, 3 to 4 times larger than the neutrophils. So they also will be nucleated, and a lot of neutrophils will be present at the site. So this is the picture, rounded acantholytic keratinocytes, the cells with the nucleus and a lot of neutrophils present. These are some squamous epithelial cells present. So we have to look into the acantholytic keratinocytes. Again, when you are seeing this acantholytic cells, you can easily see the presence of these cells like this will be very specific for your diagnosis to do that it is an autoimmune disease. Now further, if you have the facility, you can go for a biopsy and go for histopathology, and you will see very typical of acantholysis in the picture. So depending upon which pemphigus it is, again I said there, because it is 5 forms are there: superficial, whether it is deep, where the follicles are being present, where the acantholytic cells are present. So this will help you to differentiate between within the pemphigus. So if you have the histopathology facility, it will help you to know exactly which form of pemphigus is there. So this is the superficial epidermis, which has been having the pustules and lot of neutrophils and acantholytic cells, which will help you to make out that it is a pemphigus foliaceus. Again, similarly, in case of Pemphigus vulgaris, since the basal layers are being involved, so you will see the acantholytic cells in the suprabasal layer. So there will be cleft formation where the pustules formation will be present. So there will be inflammatory cells and acantholytic cells can be observed. And also, in some cases, you can see that the hair follicle and the glands are being also been involved, since it is a deeper layer has been inflamed in case of Pemphigus vulgaris. So this is just a diagram showing to clearly show you that which pemphigus causes lesion at which particular layer of the skin. So as already discussed, Pemphigus foliaceus and Pemphigus erythematosus is the superficial. So you will see on the superficial epidermis layer the pustule formation, and Pemphigus vegetans in the middle layer, basal layer, which will be Pemphigus vulgaris. The deeper side will be Pemphigus vulgaris. This is how in the different layers of the epidermis, the different pemphigus will be differentiated. Now, this technique, immunofluorescence and immunohistochemistry, not very commonly available everywhere in all the labs or clinics. So this is used for basically for the research purpose. This helps us to identify the autoantibodies which is against the skin target. So this is to, in a research purpose, helps us to diagnose pemphigus and also to know the pathogenesis of the skin. So in this case, basically, very commonly autoantibody which have been seen is IgG, and little bit of IgA and IgM also, but it is mostly IgG. Fluorescent, under the immunofluorescent, you can see the picture in the intraepidermal and intracellular region representing the presence of anti-IgG antibodies in canine patients with Pemphigus foliaceus. Now, once you have diagnosed it, whether you can diagnose based upon the clinical symptoms, if you can diagnose, or by differentiating the different diseases, you can diagnose, and if you have the cytology, histopathology, that will be confirming your diagnosis very specifically. Now coming to the therapy, what you have to start with is there are three categories which can be divided therapy into. The common therapies which is being used, you can use some alternative therapies and then some additional alternative therapies. So very commonly glucocorticoids are the first choice for us when autoimmune disease happens. And if it is a localized form, you can go for the only topical application of glucocorticoids every day for 7 days, then alternative days every 7 days. Prednisolone is the one which we can use, or you can use 1 to 2% of hydrocortisone cream on ointment. From that, when the severity is more or the lesions are quite more spread all over the body, you have to go for systemic glucocorticoids. So in that, prednisolone is the first choice. So initial dose you have to go for is 2.2 to 4.4 mg per kg body weight every 24 hours. Then you have to see the response for minimum 2 weeks. So when it is showing the response and the lesions will reduce around 80% within 2 weeks. So if it is responding well, then you can go for gradual tapering of this corticosteroid for over 30 to 40 days, next 40 days. And then you can lower on the alternative day basis until it comes to a dose of 1 mg per kg every 48 hours. And sometimes if there are some side effects being seen because of prednisolone, methylprednisolone can also be preferred instead of prednisolone, because the treatment will be going for a very long time. So this also gives very good results similar to the prednisolone. From that, the other glucocorticoids can be used in the oral triamcinolone or oral dexamethasone. So dosage for triamcinolone will be 0.2 to 0.6 mg every 24 hours. If we are using dexamethasone, it will be 0.2 to 0.4 mg every 24 hours. Then this also has to be tapered gradually, and the tapering will be every 48 to 72 hour basis. Now glucocorticoids are the first line of therapy, but if you have to, any side effects have been seen, you can go for combination of glucocorticoids with the non-steroid immunosuppressants, that is azathioprine therapy. So it is the dose used is 1.5 to 2.5 mg per kg every 24 to 48 hours. So azathioprine is the good choice among the immunosuppressant therapy, non-steroidal immunosuppressant. So this will help in interference with the synthesis of nucleic acid and is cytotoxic to T cells. So it has its greatest effect on the T cells dependent antibody synthesis. So the autoantibodies which have been produced will be inhibited, but it takes usually 4 to 8 weeks to see the clinical effects. Apart from that, the other immunosuppressant can be used as chlorambucil. It is used at the dose rate of 0.1 to 0.2 mg per kg body weight every 24 to 48 hours. So this is an alkylating agent that functions by affecting the cross-linking of DNA. The next is which can be used is tetracycline and niacinamide. This is recommended at the dose of 500 mg each drug every 8 hours for dog weighing more than 10 kgs and 250 mg every 8 hours for the dog weighing less than 10 kgs. Apart from that, there are some current alternative therapies which can be used is cyclosporin and tacrolimus. So this cyclosporin used at the dose rate of 5 to 10 mg per kg body weight every 24 hours, and the cyclosporin also available in the topical form that can be used. And this tacrolimus is more effective in cases of topical administration. So this is also available nowadays. So this has also given a good response for the topical administration. It comes in the 0.1 to 0.2 percentage can be used. The latest drug which has been introduced in case of autoimmune therapy is the mycophenolate mofetil. So this is used in the dose rate of 22 to 39 mg per kg every 24 hours divided every 8 hours. So this is a new drug that inhibits the guanine synthesis. This is required for the B and T lymphocytes dependent upon the guanine synthesis. So it it targets the or it inhibits the synthesis of B and T lymphocytes, and in turn the autoantibodies production will be reduced. Cryotherapy, this is the use of gold which helps in immune modulating and acts as an anti-inflammatory therapy. So exact mechanism is not known, but in few cases it has given good results. So oral and injection forms are available which can be used. Injection form 1 mg per kg body weight is given intramuscularly once a week, and which is oral 0.05 to 0.2 mg per kg every 12 hours. Other therapy which has been effective is dapsone and sulfasalazine. Dapsone is used at the rate of 1 mg per kg every 8 hours. Should only be used in dogs. Dapsone decreases the complement activation and antibody production, lysosomal enzyme synthesis and neutrophil chemotaxis. Whereas sulfasalazine acts as an anti-inflammatory property. It is used at the dose rate of 10 to 40 mg per kg every 8 hours. According to the latest guideline in 2020 guidelines, in case of humans also this pemphigus is very common condition, or we can say it has been seen in humans also. So they have recommended injection of anti-CD20 monoclonal antibody rituximab. So for in humans the first line of steroid sparing immunosuppressant agent most commonly used is the azathioprine and mycophenolate mofetil along with the rituximab. So this is the latest recommendations they have come up with, so which can be used in dogs also similarly. So the protocol what they follow is in humans are the glucocorticoids are used along with the immunosuppressant agent azathioprine, and now the latest is the monoclonal antibody. So the combination of all these three can be used, which will be very effective. So you have to see for minimum 2 weeks its efficacy. If 80% of the lesions have been healing, then the glucocorticoids has to be reduced in the tapering dose, which can be which will reduce the any side effect because of the glucocorticoids, and you have to start with the along with that the steroid sparing immunosuppressants azathioprine or MF. So once if the lesions are reducing, means slowly you can taper down and reduce, stop the glucocorticoids. But if it is not reducing or remission, again the occurrence of the relapse of the condition happens, then maybe you have to increase the glucocorticoids again, the dosage. But if there is a remission and there is a reducing of the clinical symptoms are seen, slowly you can taper down and stop the glucocorticoids, and then slowly only on immunosuppressants, and then that also can be slowly be stopped once the full if you have not seen any new lesions coming on the skin on the body, so slowly gradually the therapy can be stopped. This is the I would like to share the condition which we have seen previously, how it was on the lesions on the muscle and periorbital lesions. So after the treatment, the animal has been healed, and you can see the lips and the muzzle and the peri-orbital layer has been very much cured. This was after around 1 month of the therapy, and the combination of glucocorticoids and azathioprine was used in this condition. So very drastic improvement was seen. And this is the ear pinna, where the full erosion and ulcerative erosion lesions were present, and this was the after therapy. Very uh, drastic improvement. And we have not seen any side effects in this case. Otherwise, whenever you are going for long-term therapy, you have to keep monitoring the blood picture or profile of the animal. If it is for a very long time, you are using corticosteroids or immunosuppressants. So this is the after treatment. The animal has improved very drastically. So this was about pemphigus, and thank you very much. If any questions are there, I will be happy to take it.
Thank you, ma'am. Thank you for giving us a good insight on the canine pemphigus, its diagnosis and management. We have a few questions out there. The first question is, how long this therapy goes for a pemphigus treatment?
It varies from case to case. Basically, they have seen that from 1 month to even 6 to 8 months, the therapy can go.
Ma'am, in pemphigus treatment, there are the use of the glucocorticoids. So, is there any side effects of long term using the glucocorticoids?
Yeah, many times for long term when you are using glucocorticoids, polyuria, polydipsia, or muscle atrophy, these kind of things can be seen, or secondary bacterial infection starts happening, and so that is why we don't go for purely for glucocorticoids. It is always better if side effects are being seen, you start with the non-steroid immunosuppressants like azathioprine, or you can go for other corticosteroid. If prednisolone is giving any side effects, you can go for other corticosteroid like methylprednisolone or triamcinolone or dexamethasone, and keep monitoring the profile of the animal.
Thank you, ma'am. Ma'am, the most vital question for a practitioner comes to mind that when they will go for a topical therapy or a systemic therapy for the treatment. So, when they start either systemic or the topical.
If it is very mild lesions are there, like in cases of pemphigus erythematosus, it is the same as pemphigus foliaceus, but it is a very localized form is there. So in pemphigus erythematosus, you can go for topical therapy, and mild form is there, you can go for topical therapy. It will be helpful.
Okay, ma'am. Ma'am, the next question is then what process should be followed for the tapering dose of corticosteroids?
Okay, so whenever you are using corticosteroids, you go for minimum 2 weeks. You have to go for the treatment. And if it response is seen, then you can start tapering the dose for over next 130 to 40 days. You start tapering the dose. You reduce by 25% of the dose what you are giving, and then till it reaches 1 mg per kg body weight, and alternative days. That till that time you can taper the dose, and you have to keep reducing by every 2 weeks by 25%.
The last question is there any seasonal age, gender, or a breed predisposition in canines of this canine pemphigus?
There is no seasonal or age-wise any predilection. Breed-wise, for Pemphigus foliaceus, they have seen because there are some genetical predisposition in like in Akita breed or Chow Chow Collie breed or German Shepherds. Apart from that, not much. All age group animals and any season it can happen.
Okay, thank you, ma'am. Thank you. The session was quite interesting, and many of them are appreciating in their comments, especially the canine practitioner. And I, on the behalf of Association of Veterinary Dermatology and INTAS Animal Health, thank you. Thank you for being a part of the AVD webinar. And thank you. And the most important, the audience, thank you for being listening. And thank you. We are about to ending our session here. Thank you,
Thank
ma'am.
you, sir, for giving me this opportunity. Thank you, sir.
Thank you.